And we are delighted to have Professor Andrew Rule from the Mayo, who will be presenting to us on the aging kidney. It's World Kidney Day, and you will hear a lot about 850 million people with CKD, and we can find out if it's really true today. Dr. Rule is a professor at the Mayo Clinic in Minnesota. He did his medical training at the University of Washington, followed by the internal medicine residency and fellowship at the Mayo. He's led a study on longitudinal function of the kidney in kidney donors since at least 2010 or so for over 10, 15 years, with a few additional studies that I'm sure he'll be talking about today. He's the nephrology section editor of the Mayo Clinic Proceedings, and he's a fellow of the American Society of Clinical Investigations. Dr. Rule.
Thank you, Dr. Hermith, for the kind introduction. And it's an honor to present to you today. My talk today is going to be called The Aging Kidney. And my disclosures, I receive up-to-date royalties on a chapter on this topic. It's a good resource if you have access to up-to-date, if you want to know more about this topic, and I have NIH funding on this as well. So many of you may be aware that there's long been a debate in the literature, and it's leaked out into kind of the common press about the diagnosis of chronic kidney disease, particularly in older adults, and I think in more recent years, younger adults as well, especially with the change in the equation to shift eGFR values up to higher levels in a lot of people. But a lot of it has been about whether an isolated eGFR of 45 to 59 in an older person without proteinuria is a disease. And, I think it's important to start about, let's get to the nuts and bolts of what we mean by GFR. And we generally estimate it in clinical practice, usually with creatinine. And this is the formula that is being used. And it's a formula based on creatinine, age, and sex. And, you see this little number there with this coefficient age on it. And so what does that actually mean? What that coefficient and age means is that for each year of age, you have a 0.6% decrease in your GFR. So if your creatinine remains stable and you're over time, you will eventually have a decline in your GFR, likely to levels less than 60 if you live long enough. And this equation views the age-related decline in muscle, which is the source of creatinine, as normal. In other words, we model what we're doing with age is we're modeling the loss of creatinine generation or muscle mass with age, and we see that's sort of an inevitable thing that happens, but we're then using a single threshold regardless of age to define disease. So we kind of are talking a little bit out of both sides of our mouth when we use this to define CKD, because we assume inevitability for one process but not the other. And this has been shown with measured GFR as well, even in very healthy populations. In nephrology, we have access to living kidney donors who are uniquely very screened carefully to confirm health, or at least to know about their health condition so that we can account for those in the analysis. And you see this decline in GFR very consistently across the literature with age. And I think one of the better studies more recently, which is actually community-based, measured GFR combining 4 cohorts, including people with more advanced conditions that will, affect kidney function and making sure they didn't have meaningful albuminuria. And you see this decline in GFR in the green for healthy individuals, which is, almost just as much as if they aren't healthy. I think a lot of people don't realize that most of your decline in GFR is actually related to aging. It's not to common conditions or even mild kidney disease. Here's looking at measured GFR decline from that data in the healthy subset of the community. And there's a couple of points here. The light blue line is kind of the decline in women. You can look at it in men, it's similar, but basically the variability shown by the dashed line is fairly constant. It doesn't widen. If you thought that some people were losing kidney function from a disease and others were preserving their GFR, you would see a widening of the distribution. That's not what you see. You see the variability, kind of the spread in the data doesn't change with age. And in fact, if by age 70, you start having healthy people having a measured GFR less than 60, And the lower limit of normal in a 50-year-old is equal to the upper limit of normal in a 95-year-old. So it's a near universal, if not near universal process. Now, age-related decline occurs in other organs, and in other specialties, they deal with it differently. Pulmonary function tests, I think you could argue that the forced expiratory volume in 1 second, or FEV1, is the GFR of the lungs. And when this is reported, it's typically done with age-specific criteria. And even the diagnosis of COPD, which is based on the ratio of FEV1 to FVC, both of which decline with age. So it sort of cancels out, but it's still accounting for the aging process and identifying the chronic disease in their organ. There are arguments that we should recognize for using GFR less than 60 to define CKD regardless of age. And I think the most powerful one is to keep it simple. You know, we can't always have a nephrology-centered view of the world, and we need to make it so throughout cross specialties, it's, you know, not too complicated to identify patients who have chronic kidney disease. It draws attention to loss of GFR with aging, which is still clinically relevant because of medication dosing and other factors. And, you know, there are age-related phenomena such as diabetes and hypertension, which do not use an age-based definition. It's been showed in studies that a single, you know, this is not necessarily needed. I think there are arguments, however, that are strong for not using GFR less than 60 to define CKD regardless of age. It over-medicalizes aging. It's alarming to patients to be told you have stage 3 chronic kidney disease when they've just simply aged into a lower GFR with no real change in their creatinine. The risks are of an eGFR of 45 to 59 is very modest, or not even present for, you know, some of the key outcomes. It misses the diagnosis of CKD in young adults. And I know there's work from here, from your center, that's shown some of this nicely. And there's no evidence that GFR decline with age is reversible and there's benefit if reversed. So that's different than hypertension and diabetes. If we knew we could increase someone's GFR and then improve their outcomes, I think that would be interesting. But, you know, we don't, unlike hypertension and diabetes where you can show that, we can't show that with GFR. All we could do is cause hyperfiltration, which is generally not helpful. It can actually further lead to damage to the nephrons, and I'll show that later. And the biology of kidney aging and CKD are actually different, and I'll show some evidence of that as well. So just kind of putting things in perspective, the diagnosis of CKD, you know, moderate risk is the areas in pink, and you can see this group with an eGFR 45 to 59 are considered moderate risk CKD. And this is about 75% of all CKD based on eGFR less than 60 criteria alone. So, you know, I'm not going to quibble with the proteinuria definition of CKD. It's just the isolated reductions in GFR. We're going to take a closer look at that. Now, that data I just showed you, we reanalyzed it by simply defining the reference group as the eGFR with the lowest risk. And what you find is the eGFR with the lowest risk among those without albuminuria, or less, you know, albuminuria less than 30, progressively decreases with age. And so the lowest risk group in an 18 to 54-year-old is an eGFR greater than 105, but it decreases to an eGFR about 60 to 74 in the age group of over 75. And then if you look at what's a clinically meaningful risk, more than or a relative risk of 1.3, the lower threshold that risk is increased is at an eGFR of less than 75 in the 18 to 54-year-olds, but it decreases to closer to less than 45 in the oldest age group, where the risks in the 45 to 59, at least in this data, were quite modest. But I'm going to even challenge that. But I first want to make a key point is that a lot of studies in the literature are based on a single eGFR or an average of multiple eGFRs, but it's important to understand if you take data from the clinical practice, it reflects both acute and chronic kidney disease, and it takes some thoughtful analysis to distinguish those two. because, patients get testing when they're not well, when they have acute illnesses. And it's, a patient who has a creatinine of 1.4 and then 0.6 3 months later will have an average creatinine of 1. And a patient with serum creatinine of 1 and a serum creatinine of 1 3 months later will also have an average creatinine of 1. But those are two very different patients. The first one likely had some sort of acute kidney injury that recovered, that AKI could be associated with risk, whereas the other patient really more truly defines a stable kidney function that we can assess whether that reflects some sort of underlying chronic kidney disease. And it's important to understand that even though we use the same test for both, they have very different pathologies. We just often can't distinguish those when we have only a single test. So these next few studies really carefully looked at chronicity in their criteria. And this one looked at eGFR sustained for 3 or more months. And they found that in this eGFR 45 to 59, in the older age groups of 75 and older, there really wasn't an increased risk compared to higher levels of GFR. It was only in the younger age groups, and even there was fairly modest. Another study here again required the eGFR level to be sustained in this category for 90 or more days, and they excluded proteinuria. And they looked at both the young age group of 18 to 45 and the number of deaths observed compared to those expected. It was a threefold difference. And these for an eGFR of 60 to 75. So these younger adults who did not have criteria for CKD were at threefold higher risk, but they don't meet the criteria. Whereas the older adults who have an eGFR of 45 to 60 that was chronic and stable there was really no increased risk with a fairly narrow confidence interval, even though they meet the criteria for CKD. So there's this disconnect between the data and how we're defining CKD, at least with mortality. Now, some would say, well, if you look at these data, you'll still find there's a higher risk of kidney failure, even in elderly adults with an isolated eGFR 45 to 59. And there is a higher relative risk, but the absolute risk is quite minimal. And you can look at this by simply taking the kidney failure risk equation, plugging in an eGFR of 50, no albuminuria, and you'll find something like a 0.15% risk of kidney failure in the next 5 years. Certainly not enough to be alarming to the patient, I think, to tell them that they have, stage 3 CKD. So I think we should step back and ask, what is a disease? Is it just prognosis? Risk factors, including age, are prognostic, but not necessarily disease. Demographics are strongly predictive, but we don't need to medicalize everything that's prognostic. We should also consider biology. Disease organs have underlying tissue pathology. So what is the pathology of chronic kidney disease? So if we look at biopsy of a patient with advanced kidney CKD, here an eGFR of 16, the histology shows often arteriosclerosis. It will show glomerular sclerosis and interstitial fibrosis and tubular atrophy. This is a trichrome stain with a lot of blue, as you can see. And so we can think about, well, are these things present in, living kidney donors as they age? How do these things occur? And so you can look at living kidney donors and you find they're quite common. Most biopsies will show some glomerular, half of them will show at least one sclerotic glomerulus. Some degree of IFT is often present. Arteriosclerosis is very common, particularly with age, I'll show you. And you can kind of combine these together in some sort of a sclerosis score just to try and, as they often track together, try and capture a little more granularity in the data. And what you find is as individuals age, even healthy kidney donors, you see that in young adults, there's 60% of them will have no abnormality, but by the time you get to the 70, 79-year-olds, only 10% will have no detectable abnormality. The rest will have something that's chronically injured that reflects sclerosis on their biopsy. This together can be thought of as nephrosclerosis. And the interesting thing is does this explain the age-related decline in GFR? And what we found a number of years ago is that you have this decline in GFR, whether or not these sclerotic changes are detected. These sclerotic changes are more evident as you get older, shown by the red X's compared to the blue circles, but the decline occurs regardless of whether these are detected on your biopsy. So there's more to the picture that we're not capturing just by the sclerosis score, and we'll come back to this later on. This is just to show that this is a more recent study that did the same sort of analysis, but in patients who had a nephrectomy for a tumor, and they show a substantial decline in eGFR age, even with those who had minimal sclerotic changes on their kidney biopsy or on their kidney sections of the non-tumor part of the kidney. And I just wanted to show that the decline in GFR from ages 25 to 75 was about 35 milliliters per minute, more than about double what you get from going from grade 1 minimal to grade 3 moderate sclerosis on your biopsy. So again, the effects of aging on kidney function decline are quite pronounced, even relative to what we see with chronic kidney disease. So let's try to understand, why does GFR decline with age, and what's the underlying histopathology? Maybe it differs by depth. One of the advantages we have found with studying these patients who have radical nephrectomies is you can get large wedge sections and get a more complete picture about what's going on in their kidney. And here's showing you a wedge section where we annotated all the glomeruli at 5 different depths to try and see if there's a difference and the patterns of glomerular sclerosis shown by the pinker annotations compared to the ones at each depth for the non-sclerosed glomeruli. And you see that shown on the graph here on the right, that in the superficial part of the cortex, there is a much higher increase in the percent of glomeruli that are globally sclerosed than in the middle and the deep. And if when you do multivariable analysis, all the increases with age is in the superficial. There's actually no increase in the middle and deep if you account for the increasing comorbidities in this population as they age. And but you do find that the comorbidities, things like hypertension, lower GFR, proteinuria, interstitial fibrosis, occur at similar levels across the depth of the kidney, unlike the aging, which is almost all in the superficial. So you can kind of think of the effects of various clinical parameters on your kidney histology for glomerular sclerosis as being both a disease-related pathway that occurs independent of age, which is more diffuse across the depth of the kidney. Diabetes was actually higher in the deep part of the cortex, whereas age-related glomerular sclerosis is nearly all in the superficial cortex and largely absent in the deep cortex. Now, the reason for this isn't entirely understood, but it's a very different pattern and suggests there's different biological pathways between how we lose nephrons between aging and chronic kidney disease. We also looked at maybe there's something in the imaging that could explain this. You do see on CT scans of patients who have contrast-enhanced scans that sometimes people have a focal scar. You can see the kidney on the left has an area of substantial attenuation of the cortex consistent with the scar. And if you looked at people presenting to donate your kidneys, these do increase with age, though the prevalence is still quite low, 8% in the oldest age group. Cysts also increase with age, and they're fairly common. They only affect a small amount of the parenchyma, but they do markedly increase with age and may reflect some of the age-related changes that occur in the kidney. But what we also looked at was kidney volume, and a lot of focus is on total kidney volume, and then you have to clarify what people mean by that. Do they mean the renal pelvis? But if you just care about the parenchyma, I think that's getting closer to what matters for kidney disease. But I think even beyond that, separating the cortex and the medulla can be even more informative, as I'll show you here in a second. What we have done is used initially manual interface to annotate the cortex of the kidneys in a lot of kidney donors, as well as patients undergo nephrectomy for cancer. And we have now trained AI models to automate this, and those actually work quite well. And what you find is that for each 10 years of kidney aging, you lose about 4% of your cortex. And what's interesting is the renal columns, also called the columns of Burton, that divide the medullary pyramids, thin and become less detectable on CT. You can still see them on histology, and this has been shown in some nice work in recent years. But because of this thinning effect, you actually lose pyramids when you count them individually. You lose about 1 pyramid every 10 years because you have about 20 on average. And they're 9% larger, which is consistent with the merging of pyramids together, which increases the average volume of them. So there is this kind of atrophy of the cortex that leads to the pyramids kind of merging a little bit. And this is kind of some of the structural changes with aging. Now, what we found, I think that's the most informative to understand aging, though, is to actually quantify an estimate of the number of nephrons in the kidney. And we've now done this in 2 different populations. We've done living kidney donors as well as patients who have a radical nephrectomy for tumor. And basically what we do is we take this segmentation of the cortex to get the cortical volume of the retained kidney. And then of the kidney that's removed, we look at the histology either on biopsy or on wedge section for the nephrectomy patients, and we estimate the 3-dimensional density of glomeruli. We account for tissue shrinkage and loss of perfusion pressure, and we get an estimate of the number of glomeruli in the per kidney from this calculation, density times volume. You get the count. And what we find is that there is this fairly marked decline in the number of nephrons in the kidney with age, from about 1.5 million to approaching to 1 million. And this is higher in the healthier population, living kidney donors, and patients with tumors. And this is actually can be explained by differences in comorbidity. If you adjust for the hypertension, the diabetes, the obesity, proteinuria, all these other factors, you find no difference in the nephron number estimates between these 2 patient populations. In fact, they converge nicely. Now, this is not detected on histology. And to show you this, if you look at the biopsy on the left part of the bars versus the total estimates of nephrons that are non-sclerosed, and we can also estimate them for globally sclerosed glomeruli, what's missing, from our compared to the youngest age group, isn't being detected on histology. So you have a more marked loss of nephrons than is being reflected by the percent glomerular sclerosis on biopsy, because when we calculate the total number of glomeruli that are non-sclerosed and globally sclerosed, add them up, it doesn't add up to what you should have if you were in the younger age group. And so there is this progressive atrophy of, this has been well described in even the older literature, that glomeruli become obsolescent, they progressively atrophy, and eventually become undetected on renal histology. And what's interesting is this same phenomenon appears to also happen with IFTA, interstitial fibrosis and tubular atrophy. Here's typically what you see if you compare an older section of the kidney to a younger patient, who have both of these patients had radical nephrectomies, one's younger, one's older. And you will see that of 2 individuals with the same percentage of their cortex that's interstitial fibrosis and tubular atrophy, the older patient will tend to have more foci than the younger patient. And we showed this statistically, and what we think is going on is, excuse me, when nephrons are injured, you get IFTA, you get global sclerosis as these nephrons are being lost. But the IFTA is a progressive process. Histopathologists will just talk about kind of immature IFTA, mature IFTA. You get progressive atrophy of these foci, and this actually contracts the cortex. I mean, we should ask, why does the cortical volume decrease? Well, these foci of nephrons that have sclerosed, they become more atrophic, and this increases their density because you get more. You have now a contracted cortex, and these little foci were once larger, and they progressively atrophied over time. And so what this means is that as you age, you can have minimal increases in IFTA despite substantial nephron loss, because this gradual indolent process with aging keeps progressing. And here's just to kind of bring the point home, you will often find in kidney donors, if you take their glomerular density and their cortical volume, if they're young, you might get something like the example above, 2 million nephrons and a measured GFR 148. But this older patient who has a fairly preserved kidney biopsy, maybe you'll find some regions of a little bit of sclerosis, but they're very small. They'll also have a relatively preserved GFR, but if you calculate their nephron number estimate, it'll be far fewer, and their GFR will be far lower. And so this seems to be a process that occurs with aging, and it doesn't lead necessarily to a lot of chronic histological changes. It does lead to some, but not to the level you'd expect for that degree of nephron loss and GFR decline. So the question we can ask is, why don't we compensate? Why isn't there glomerular hypertrophy and hyperfiltration, which is known to occur in obesity, diabetes, hypertension? We can target this hyperfiltration and its effect on the proximal tubule with ACE inhibitors, ARBs, SGLT2 inhibitors. Proteinuria is kind of the manifestation often of this hyperfiltration. But with the kidney aging, you see this marked decline in nephrons, and there's no proteinuria. Why aren't the remaining kidneys somehow trying to compensate, or are they? And maybe they are compensating. We just don't see that this doesn't cause proteinuria. Well, as I mentioned, there is this decline in nephron number with aging. We see this in both donors and tumor patients. But if you look at the glomerular volume, this does not increase in either population. You do see larger glomeruli in the tumor patients than the living kidney donors, consistent with a higher comorbidity burden. And again, if you adjust for that comorbidity burden, these lines completely overlap, and there's no difference between the two groups. The other thing we can do is we can take our estimate of nephron number, and we can use that to calculate single nephron GFR. We use measured GFR with the iothalamate clearance, a gold standard method, divide that by the number of nephrons in both kidneys. And we can see that single nephron GFR in microliters per minute is actually very strongly correlated with glomerular volume. And as you'd expect, they're both measures of kind of the glomerular structural function relationship. And we find that despite this large loss of nephrons, and this is compared to the youngest age group, the 18 to 29-year-olds, each older age group, there is this decline in the GFR shown in the light blue, but there's a similar decline in the nephron number that's explaining this GFR decline, and single nephron GFR stays relatively unchanged, relative over time. It doesn't increase to compensate. So in summary, GFR declines with age from nephron loss due to nephrosclerosis. It seems to be more of a superficial, maybe ischemic process. And I forgot to mention that the glomeruli in the superficial cortex that you are not sclerosed often have more of an ischemic appearance with capillary wrinkling and some Bowman's capsule thickening with age. And then you see the globally sclerosed glomeruli progressively atrophy until undetectable. You get IFTA foci that atrophy until undetectable or very small at least. And then the cortical volume is relatively modest, but the nephron loss is actually more severe than is seen on biopsy or CT. And it appears that the glomerular volume and single nephron GFR do not increase to compensate for age-related nephron loss. So let's get back to prognosis here. And so we've talked earlier about how GFR is, what we've assessed kidney health with, but it's really not the gold standard. It's simply something we can practically estimate. Structural pathology is the gold standard for disease in an organ. And so I think it's worth asking, is this age-related glomerular sclerosis and IFTA prognostic for progressive kidney disease? And here we're going to look at kind of a 40% decline in GFR or kidney failure as progressive kidney disease. And so what we did is we annotated glomeruli and IFTA on a large sample of kidney donor biopsies to obtain precise measures of percent glomerular sclerosis and IFTA with age. And our strategy here is that we looked at the chronic changes on biopsy, and we defined both what's normal compared to young. So we figured out what's the 95th percentile for young, and then we defined the 95th percentile for each age group, and above that we called abnormal for age. But between those two groups, we have what's called normal for age, but abnormal compared to young. And that's the group we're interested in, is that if you have more chronic changes in a young adult, but not what's abnormal for your age, is that prognostic? Well, first let's look at it for a couple of things. So for glomerular sclerosis, the percent of glomeruli that are globally sclerosed, this actually increases from about 1.17 in the youngest age group, which defines what's normal compared to young, up to about 16% in the oldest age group. And if we look at percent IFTA, this also increases from about 0.18% in the youngest age group to about 6.5% in the oldest age group. Now, these are very precise. A lot of people have been, a lot of data is based on kind of visual inspection, and, I'm going to give this a BAMP CI score. This is actually carefully annotated every area of IFTA and every sclerotic glomeruli to get a very quantitative estimate of these processes. So if you look at the risk of progressive CKD, in the top, we're comparing normal compared to young to normal for age, but abnormal compared to young. So just the age-related changes that are not abnormal for your age. You do not see an increased risk when we apply these thresholds either to patients who have a kidney tumor that are followed for progressive kidney disease, or patients who have a kidney biopsy for kidney disease and are followed for progressive kidney disease. So two very different groups, neither one were these age-related sclerotic changes prognostic. Only, as shown in the bottom, if they were beyond what was expected for age, your age-specific 95th percentile, glomerular sclerosis and percent IFTA were both prognostic for progressive kidney disease. Here's another study we did earlier, another way of looking at it, just defining the 95th percentile for number of globally sclerotic glomeruli per section based on your age of your patient and the number of glomeruli. And as you can see, the older you are, the more glomeruli you have, the number of globally sclerotic glomeruli that defines the upper limit of normal increases. So if you had more than that, more globally sclerotic glomeruli than expected for your age, you had a higher risk of progressive chronic kidney disease in this large cohort of nephrotic syndrome patients that we followed for outcomes. But if they were within what was normal for age, or you had none of your glomeruli were sclerosed, there really wasn't a difference in the risk of CKD progression. So I would argue that if underlying gold standard tissue pathology for CKD requires age-based thresholds, so should estimated GFR. So let's come back to estimated GFR here. So I showed you earlier measured GFR. This is just showing you estimated GFR. I just wanted to make the point that this declines with age. This is an older equation, but really you see the same finding regardless of the equation you use. But the decline is similar whether you look at the general population or living kidney donors. You see this kind of spread in the data. It's fairly constant. It's progressive. Now the argument is that if we were to use this data to find lower thresholds for CKD that were age-based, that this would be complicated. We'd have to look. You couldn't say a single number because it would depend on the patient's age. And then you're like, well, how granular do we need to make it? Well, creatinine actually has a unique property, and that is that the age-related decline in GFR and the age-related decline in muscle mass are similar, such that when you look at the change in serum creatinine in kind of a healthy population like kidney donors, there's really no change with age. And this is true in men or women. And if you look at what's the 97.5th percentile, kind of the upper reference level for serum creatinine, it's 1.26 milligrams per deciliter or 111.6 micromoles per liter. And in women, it's 1.05 or milligrams per deciliter, 93 micromoles per liter. And it really doesn't change much with age, at least in a population we could define healthy. It gets to be more complicated. Of course, you get into people over 70, it's just what's health in that age range. But the way you can interpret an abnormally increased serum creatinine level is that it represents a low eGFR per age. We could convert this threshold into eGFR thresholds that are reflecting the lower limit for age. But this keeps it simple. The first thing I ask is your creatinine elevated for what would be expected for a man or for a woman? And let me kind of finish up with this example, with this question: which patient here needs more care? You have a 20-year-old man with a stable serum creatinine of 1.6. This is well above the 97.5th percentile for normal, which is 1.26 in men. This patient's eGFR is still above 60, so they would not, per the lab computer, be identified as having chronic kidney disease. It might be this person is a weightlifter and they have a lot of muscle mass, but we don't really know that. And it's very possible that this individual has chronic kidney disease, and I think they deserve at least an evaluation for that. On the other hand, we have this other patient, 80-year-old woman with a stable creatinine of 1. It's within the upper limit of normal for women, but her eGFR is less than 60. And this patient will often get a lot of referrals, a lot of additional testing, maybe even a lot of anxiety about their diagnosis. So I would kind of summarize my talk with the following. I think there are structural and functional changes in the kidney with aging. We kind of have a single threshold approach, which I think has some downsides to it. First, it captures eventually healthy individuals as having chronic kidney disease, because part of the aging process that it appears to be nearly universal, if not universal, is loss of nephrons due to nephrosclerosis, which also further atrophy, so you don't even always detect the amount of chronicity. And then on top of that, you have aging with expected comorbidities, hypertension, diabetes, obesity. These can stress the remaining nephrons, cause larger glomeruli. These commonly occur with aging and accelerate the loss of nephrons. And then I think you have what I would call bona fide chronic kidney disease, which is a specific pathology, specific process, a nephropathy that causes, some sort of a specific pathology to the kidneys and further loss of nephrons. And I think our challenge as nephrologists is to make the distinction between these and to appropriately treat the patient and follow them based on where they fit here. And I will end here and take any questions. Thank you.
Fantastic. That was a really nice overview of the topic, Dr. Rule. If people have questions, please raise your hand and ask them. And while people are thinking of what to ask, I'll start the ball rolling. How should we think about GFR and CKD staging? Would you say that there are these other equations which take age into account separately, like the full age spectrum and so on and so forth? Is that one way to approach GFR, or would you say we should get rid of that CKD staging? Because even if I don't call it CKD, someone will label it as CKD stage 3, and people get that diagnosis. It's more a philosophical question perhaps, but what are your comments on that?
Sure. So I would take sort of the approach that pulmonary medicine does, and I would say, I would say that older individuals, when they develop chronic disease in their organ, often will be at a higher stage when they present. In other words, I think we need to distinguish, does this patient have a disease? And then once we decide they have a disease, then decide how severe it is and recognize that older people will often enter into a more advanced stage because they've had this age-related process that's going on. So, I think the eGFR of 45 to 59 is problematic. Now, with the newer equation, which gives everyone a little bit of higher GFR, I think it's kind of shifted some of the problem to underdiagnosis of younger individuals than older individuals. But, regardless, the problem is the one size fits all and not accounting for the aging kidney. So I think we can first just identify diagnosis, and I just don't see a lot of value with using eGFR for the diagnosis. I say, is your lab test abnormal? And then if it is, then we make the diagnosis, then we can decide how severe it is.
It makes sense. Peter, you had a question, or yeah?
I guess a bit. Mostly I wanted to say thanks, because this is a topic close to my heart, and I completely agree with you. I guess a couple of issues. Well, you didn't talk a lot about proteinuria except tangentially to say, let's diagnose a disease before you start talking about how severe it is. And I think mostly the marker will be significant proteinuria. I do wish actually we had adopted one of those other staging systems that have age in it, but I don't know why people think it's too complicated. We all have calculators built into computers, and labs could easily do it, but seems we're not going that way. Big issue is not much day. You know, your graphs mostly stopped at 75 because you're working on living donors mostly. So nobody ever tells us what's a normal GFR when you're 90, because certainly overzealous family physicians and others are often diagnosing stage 4 CKD in a 90-year-old who looks pretty normal to me with a GFR of 30. Any comment about what we should do with the very old?
Yeah, that's a great question, and I think, you know, it is more complicated to define an age-specific reference range in elderly individuals. Now, one study, I did show one study that I think is helpful here. If you don't mind, I'll just kind of go back to that and share that real quick. So this is 4 community-based cohorts that actually had measured GFR, and they extended, you know, to people in their 90s, you know, or at least 80s. Let me share screen again. Oh, are you seeing my screen or not?
No, not yet.
Okay, I got to figure out how to. You know what the problem is I'm sorry, my sharing skills with PowerPoint are being stressed here.
Yeah, Teams and PowerPoint don't work.
Let me see if I hit escape, if that'll work. There we go. Okay, now I can share.
Yeah, we can see the other.
There we go. Yes. Okay, so this right here, you know, they did extend their data. And, you know, even in healthy adults, there's a fairly, if you kind of look at the spread in the data, you're right. I mean, even in those that are healthy, you know, you do get people with GFRs that go, you know, well below 60. I would say that it would still be an improvement just using an abnormal serum creatinine level in older patients, because right now we're overcalling it substantially in this group. Now, some people would argue that that's not good enough, that the upper limit of normal for serum creatinine should increase as you get older, because there is data there. But I would still say, compared to what we're currently doing now, this would at least lead to fewer older individuals being told they have CKD with normal serum creatinine levels. I would certainly agree with you, though, that may not be enough.
Thank you. The conference room, and then Dr. Noel.
Hi, Andrew. This is David Mascott, one of the nephrologists. I wanted to get your thoughts on SGLT2 inhibitors. In the EMPA kidney trial, I think in patients who had no proteinuria, you know, you even saw a kind of a almost stabilization of decline in GFR with SGLT2 inhibitors. What are your thoughts as to, you know, could these actually be, I guess, reversing, maybe not reversing, but halting the aging process? And I know you got to, we don't really see compensation and hyperfiltration compensation in normal aging, but could that be what's going on? And could SGLT2 inhibitors have a role in that eventually?
Well, that's Great question. My understanding, and I'd love to see the paper and the data you're referring to, because my understanding is that these SGLT2 inhibitors have been shown to be clearly beneficial in patients with proteinuria, but in patients without proteinuria, that's much less clear. I can't comment on that because from my review of the literature, that's not what I'm aware of. But I would love to look at that study more closely because that's directly challenges what I'm saying, and I need to understand that. So what study is this? Which paper are you referring to?
So I think it was the EMPA kidney trial
Okay.
from a few years ago, and these were patients with CKD who had GFRs, I believe, less than 45, but they showed that even in the patients without proteinuria, the decline in GFR was slowed down with SGLT2 inhibitors because they included even patients with essentially up to minimal or like truly trace proteinuria. I think a urine ACR less than 30, they had included patients.
And they looked at that group specifically, I take it. Well, if they had GFRs less than 45, I mean, I've largely argued that the 45 to 59 in the elderly is more the concern. I would say generally anybody with a GFR less than 45 likely has chronic kidney disease. That's beyond just aging. So it'd be interesting though to see if anyone's shown this having a benefit just for the aging kidney, and I'm not aware of in people who have no proteinuria but just have older kidneys that this will somehow prevent the decline with aging. It's hard to show, as you might imagine, without a very large sample size because the decline is fairly gradual, and you would need a very well-powered study to show this, I think, as part of the aging process.
Yeah, thank you.
Exactly. Yeah, it would be a miracle, like SGLT2 inhibitors stop aging or something like that if it's true. They are fantastic drugs, but we'll pass on that for now. Greg Nolan.
Andrew, how are you doing?
Good to see you, Greg.
Yeah, good to see you again. So I think you're kind of preaching to the choir here in Ottawa with what you're saying. I suspect this talk would be quite hostile at some institutions, not to name them. But the question I had is, I know you're kind of shying away from age-related cutoffs and just looking at the creatinine. But what do you do with your living donor program now? Do you have kind of an internal, GFR based on age where you will look at these?
So great question. We actually have been using measured GFR, and so we do have to use age-specific thresholds, and we have a lookup table based on like the 2.5th percentile of people presenting for donation. We can at least see the because we don't just use 80 for everyone. I mean, an older donor. In fact, you get people hyperfiltering if you use some of these thresholds. I think you're going to select out people who hyperfilter. But we have some challenges, of course, because all of our data has been based on iothalamic clearance, and that's no longer on the market. So iohexol clearance gives us a higher value than iothalamic clearance, so we have to somehow recalibrate our thresholds, and we're still trying to figure that out. There was a recent NIDDK conference on reassessing GFR and kidney function, how we assess it, and so some of these issues kind of came up, but there is also a group working on a standardization for GFR measurement, and until we standardize, it's hard to come up with reference ranges. I know a lot of transplant societies will have kind of an age-based threshold. The KDIGO doesn't, but the other groups do. But if we don't have a standardized approach to measuring GFR, it's hard to use these across centers. So there are some efforts to try and figure out how to standardize GFR measurement.
So in the living kidney donors, you would not really be looking at eGFR.
No. We always use measured GFR to make those decisions. If there's a huge discrepancy, we might repeat the measured GFR test if we think it's not plausible, because occasionally you get a problem with the timing or the urine collection.
And one last question: Have you tried, with your own lab or some other lab to institute any kind of quote age-related normal eGFR with a value in a range? Like, do you have a kind of something that you would propose?
Well, our lab still reports the upper reference limit for serum creatinine. I'm just arguing we should consider that. Is there serum creatinine abnormal? And that's sort of reflecting an eGFR lower than expected for age is what I'm arguing. I don't think it's perfect, but I think, as long as labs, what I'm concerned about is somebody has an abnormal serum creatinine level and their eGFR is greater than 60 and it gets ignored. Why would a non-nephrologist worry about it? They're told to only look at eGFR, right? So if the eGFR is greater than 60 and the creatinine is 1.5, or they might not do anything about it. So I then when the serum creatinine is normal, I'm just more. I think we should be more reluctant to say that's CKD, without additional testing, such as proteinuria, obviously would be criteria.
Thank you, Andrew.
So before we go to Ayub, there was a question in the chat about is there any utility looking at older folks who have a normal GFR? For example, if you have an 80 or 90-year-old with a creatinine which is low and the GFR is normal, is there any utility at looking at those people to understand this phenomena? Or is that very uncommon?
I'm trying to understand the question. To understand kind of what's the range of GFR, you can't use GFR to define your population. So you could look at older individuals with normal serum creatinine levels. I think you're going to see a wide range in GFR. I think that's sort of what was done in that study I mentioned. They did kind of divide them. There was kind of a population-based study. So they randomly sampled people without selection on clinical factors, and then they broke them into those that were healthy and those that they would consider unhealthy. And the healthies, once not using GFR criteria, but they had lack of significant comorbidities or proteinuria, basically. And they still see this marked decline in the GFR with aging. So they were able to extend their range of what they think the values of GFR should be to a much older age range. And actually in that graph I showed you in women, if you get up into the 95-year-old, it would be about, the lower limit of normal would be about 40 based on that. So, it's, I think CKD is common and it'll still be common in older individuals, even if we use, I think there's been this idea that, well, if we don't use a single threshold, then we're going to miss CKD in older individuals. No, it'll still be there and it'll be more common, but we're not going to just overinflate it to make it so that we combine the normal aging process, and so it starts to become a meaningless diagnosis. I mean, I'm more concerned about the older individual who does have CKD, but the last 5 individuals that got referred to the nephrologist, we said this is just aging and we didn't do anything about it. So they don't send the one that really has the problem. It's kind of the boy who cried wolf too much. If we make our disease so universal in the elderly, it hurts our ability to help those patients, I think.
Yeah, the discrimination does become harder. Ayub. You're muted, Ayub.
Thank you, Andrew, for an excellent talk. I needed a clarification when you showed that less than 30 proteinuria. That is in American units, right? You mean less than 3 milligrams per millimole in Canadian units, correct?
Yes, that's correct. I apologize. I didn't update my slides to international units. I don't know why America has to do everything differently, but that's where I live.
So the question I had is, there's a lot of emphasis on eGFR. And if we just say that if the creatinine is normal, there is no CKD, we are going to miss a lot of CKD with proteinuria. So don't you think we should ask people, if you are screening for CKD, you need 2 tests, measure of proteinuria as well as creatinine?
I would agree with that, but that's not what happens in the routine clinical care, partly because one's a urine test. If you look at any clinical database, you'll find almost everyone gets a serum creatinine test. And, so part of the problem is a lot of serum creatinine testing isn't per se screening for CKD. It's just any clinical encounter. Maybe there's something going on in the kidneys. Let's check a serum creatinine. And it's just part of all the standard panels. Generally when people are doing a urine albumin to creatinine ratio, they're putting some thought into it. Hey, there's something. And so, the reality is we screen people even when we don't intend to, because the lab computer will report their eGFR with their creatinine test. But I don't disagree with you. I mean, I think if you are concerned about the patient of chronic kidney disease, you should do more than just check an eGFR. But we have to recognize that serum creatinine testing will continue to be done on almost any clinical encounter, and we have to recognize that the pretest probability for CKD in a lot of these patients could be quite low, but they're still going to be de facto screened if we report their eGFR less than 60.
So shouldn't we just try to educate people that eGFR really is not the biggest risk factor for progression of kidney disease and cardiovascular mortality is really proteinuria and not creatinine or eGFR? Shouldn't we be going ahead and getting that message out to our family doctors?
Yeah, I think as we all know, there's an underappreciation of the importance of proteinuria in chronic. And if you think about our staging system, it didn't help, right? Because even though we've kind of have this new kind of grid where you have urine albumin and GFR, the codes that we assign, stage 1 and 2 are all based on proteinuria, and stage 3 through 5 are all based on GFR. And the only thing I ever use the CKD staging system for is for my diagnostic codes. And I think that's probably true for most primary care doctors. So we've kind of said, oh, proteinuria is early and low GFR is late. And so I think they're like, well, if I at least check eGFR, then it's going to check the more advanced disease. And so I think that's kind of been part of the problem, at least.
Thank you.
Thank you. We have another last question, if you will, from the chat. It's about a couple of questions. One is, have you or anyone else looked at urinary biomarkers to distinguish aging versus, healthy aging versus unhealthy aging? Firstly, and secondly, from a biology perspective, it's interesting that the more superficial cortical glomeruli are the ones most impacted as the kidneys age. I think these are the ones that develop the last. So is that a factor why they are lost early? Do we know a little?
Yeah, so in terms of urinary biomarkers, I would argue urine albumin, of course, is not part of the aging. That's helps you distinguish aging from kidney disease. But I'm not aware of any, specific biomarker for distinguishing aging from kidney disease in the urine. I do think this, what's interesting is when I started looking at the superficial cortex, I was talking to our renal pathologist, and he said, oh yeah, this is well known. It's like, well, how come nobody's reported it? But he says, yeah, when older patients, we often see some sclerotic glomeruli right under the capsule. And we did find some evidence that they correlated with arterial sclerosis being present on the biopsies. And that's, of the histological changes, the one that's, I think, most strongly associated with aging is arterial sclerosis, intimal thickening. It's very, I wouldn't say that's the only thing, or that's the only causes aging, but that's a very strong finding in the aging process. So I said, and you do see kind of these ischemic changes in the non-sclerotic glomeruli. So now, the blood supply to the kidney, maybe these are the more distal perfused glomeruli. Maybe that's part of the pathway, and this is part of the arterial sclerosis of aging. I don't know more than that in terms of the developmental biology, but if you look at the way the kidney is perfused, that certainly might play a role in it.
Fantastic. Thank you again. We are up at the hour. Thanks, Dr. Rule, for that wonderful presentation on the aging kidney. And I think we have solved the CKD epidemic today. But happy World Kidney Day, everyone.
Hopefully, I've reduced a few million people from having kidney disease today. Thank you.
Thanks, Andrew. See you later.
Thank you.